have huge opportunities to help the patients, and education is very important.
It's not just about great vision. Providing great vision is one thing, but we want to provide a great experience for the patient.
Possibility for smoothing the cornea. I think this is one of the major advantages.
We try to optimize the time of the patient and try to monitor their feedback. And I think patient satisfaction is the most critical for me.
That's fantastic. Angie, I can tell you your patients will be extremely happy. It was a perfect procedure, so well done.
Epithelium is the mirror of stromal smoothness. We have been amazed by the chance to measure the epithelium regularity.
When we see some of the irregular stroma after the epithelial heals, we definitely have more regular cornea.
I think it's very important to have your patient with you here because, that's a one-time surgery in life.
We have great minds here designing a treatment based on the data that we're assessing.
There is a motivation for patients, and when there is more patients, it will be good reference for others.
With the actual length measurement, it designs a three-dimensional model of each eye it evaluates.
Technology developed more, and we can obtain more precision, better results.
This is changing the game a bit, and refractive surgery is now well admitted.
I think we all know that we're not just aiming at 20/20 anymore. We're aiming for the best possible vision. And this is the promise that we're working on today with our patients.
Hello, everyone. Welcome to the second Virtual Refractive Summit. Welcome back. We are so happy to be here again, another week together. And today we're going to have so many surprises. It's going to be incredible. We're going to start because we have a lot of content. And we're very, very, very happy to show all the things that we have today for you guys. So, as you know, in Oftalmo University, we love to say that industry and academy work together. We're very happy to have this partnership with the Alcon Experience Academy. This is our second Virtual Refractive Summit. And today I want to introduce Robbie Palmer and May Soon from Alcon. Hello, guys. Thank you so much for being here with us.
Thanks, Andre. I'd like to welcome everyone for joining this second event. I'm Robbie Palmer. I'm the International Director for Training and Education for Alcon. Super excited to be here on this program today. And I'd really like to thank the team at Ophthalmo University for the work that they've done to develop this 4-part series. At Alcon, we're committed to supporting education across the globe and specifically in Asia Pacific, through our educational portal, alconexperienceacademy.com, and events like this. It's important to support the partnership that we have between academic organizations and industry like Ophthalmo University. I do want to let everybody know if you missed the first event, it's available right now on demand, both on alconexperienceacademy.com and on Ophthalmo University's YouTube channel. Today, we have the privilege of hearing from Dr. Arthur Cummings from Ireland, Dr. Pierce Lim from Taiwan, Prof. Zhang Fengju from China, and Dr. Rick Wolfe from Australia. Hey, May, would you like to share a little bit with everybody what we can expect from these esteemed speakers?
Well, Robbie, our audience will be in for a treat as our speakers will be sharing about the best tips and application of Wavelength EX500, FS200, and Topolizer for their practice. There will even be a 360 experience of the refractive suite with Oculus. So please sit back and enjoy this exciting session.
Thank you so much, guys. It's an honor to be here with you, working together. I want to say hello to Dr. Wolfe, Dr. Professor Zhang. Hello, guys. Thank you so much for being here. Dr. Arthur Cummings was flying. Unfortunately, he won't be here in live, but we have an incredible session. Also, we have the honor to have Dr. Thomas Campbell from Australia. Hi, Thomas. How are you?
Hi, guys.
Thanks for being here. Thanks for sharing your knowledge and all your experience here with us. Dr. Ben Lahoud from New Zealand. Hi, Ben. Thanks for joining us.
Hey, good to be here, Andres. Thanks for having me.
Thank you so much. And also from Philippines, Brian Orange Kayan. Thank you so much, Brian.
Hi, good evening.
Well, as you see, we have panelists from all over the world. So let's start with this amazing meeting. I want to tell you a little bit more about the Oftalmo University. As you know, we are an ecosystem, and you will find in our website podcasts, courses, webinars, everything you need to improve your practice, your knowledge in ophthalmology. We have 3 bases here in Argentina, where I'm at right now, in Mexico City and in Barcelona. I want to say hello to Jason Pennycock. He's in Mexico, part of the Oftalmo University. Jason.
Hey guys, how are you doing? Glad to be here.
Thank you, Jason. It's also Ivo. I don't know if Ivo, you can say hello because you are setting up everything in our headquarters. Hello, Ivo.
Hi guys, how are you?
Good, good. Remember, guys, we're going to have a 360 experience. It's going to be amazing. And in Barcelona, my good friend, Lisandro Carnielli. Hello, doctor. How are you?
How are you, Andres? Hi, everyone. Nice to meet here, to be here with you.
Thank you so much, Lisandro. So, guys, if you can go to menti.com, you will find a short survey. You have to put the code 85462802. And we have just 2 questions, and then during the meeting we're gonna talk about it. So the Virtual Refractive Summit, it's an online summit, as you know, that we have specially designed to enhance our experience, knowledge in refractive surgery. We had the first one for Europe in June, and now we are designing this for the APAC region. Why lift as you climb? Because we think that it's time to live as you climb. As we continue our climb to the summit, we must lift and support our peers because we all want to rise our practice together. So lift as you climb means collaboration with our peers, contribution, and expansion of our full potential. We have the APAC ambassadors here, as just mentioned, like Thomas Campbell, Ben LaHood, and Brian. Thank you so much, guys. And for the young ophthalmologists, Asian Pacific Association, we have scholarship. So if you are part of the 4 webinars, you can be one of the winners of our scholarships and go to our headquarters in Mexico and have one of the refractive surgery programs. So if you want to be there with me, with Alessandro, with Nivo, you have to be part of the website. Our community has an Instagram account, so you can be updated about all the activities that we have around the world. You just can take a picture of this, look at this, of this QR code, and you will go directly to the Instagram account. I want to say hello, hello and thanks, of course, to the Media Mice community. Thank you so much for your support, guys. Before we start, remember, guys, we are you are in a listen only mode. You can hear us, but we cannot hear you. We are recording this webisode, and you will be able to view this webinar on demand later in the iconexperienceacademy.com in the Oftalmo University YouTube channel. Please don't be shy. This is for you guys. It's not often to have all these amazing panelists all together, so let's take advantage of them, and please ask, use the chat, and let's make this very dynamic. One more thing, again, if you go to menti.com, please vote and help us with the survey 85462802. So we're going to start right now. And as I just mentioned, Dr. Arthur Cummings, he's not here, but he recorded a great lecture that is the main lecture for today. So, Lisandro, you just tell me if you can see my screen, and I'm going to start with the Dr. Cummings presentation.
Hi, good day. Thank you to Oftalmo University and Dr. Andres Bonatti for this very kind invitation, and my apologies for not being able to make this live. It just so happened that my flight was changed and it landed up being at exactly the same time as the meeting. So I hope this recording works and hope that it gives you at least some food for discussion. I look forward to seeing the discussion afterwards. So I've been asked to speak about 5 different tips for different scenarios, and I hope that they generate discussion. So my 5 best clinical tips for application for your practice. I'm going to be speaking on 5 tips for the FS200, on 5 tips for Streamlight, and on 5 tips for the Topalizer. So on the FS200, the preoperative instructions are really, really important, and the verbal anesthesia, speaking to the patient as you're progressing with the procedure. And the first thing that I want to make certain of is that we reduce the Bell's phenomena. People tend to look upwards when they're feeling afraid and when they can't see. So I'd speak to the patient up front, telling them to look at the white circle of light. As we get closer, to look down into the tunnel, into the back of the circle. Sometimes people can see a colored tile in the back. And then I'd say to them, as soon as things go dark, that they imagine that they're looking at something on the ceiling, an imaginary point. And when it goes dark, they simply keep on looking there. And that tends to help a whole lot. The next thing is applanation of the suction ring prior to applying suction. So what that means is the patient's looking up at the light and you place the ring on the eye before you apply the suction, and you stretch back the conjunctiva, that you're applying it to a firm eye and not an eye with loose conjunctiva. Then you apply the suction. The next thing is when you're making the channel is to extend the channel to the area where the air bubble escape is optimized. Over time, you'll see what this is. It's normally close enough to the red line, but typically slightly beyond that. And try and get it to where you know the channel is opening into space as opposed to opening into an area where it's still very compressed. Center on the corneal apex. It's always simple afterwards to recenter to wherever you need to. And then it's important that you adjust the spot energy and the energy in the spot line separation until your flaps are optimal. Mine changes over time. My current setting I've had for the last couple of years and seems to work really well. And is 6 millijoules and a spot line separation of 0.6 by 0.6 micron. So looking at FS200 planning specifically, when doing a custom flap.
All right, so what we're going to do here is load a patient for a basic procedure. And you can see the data we have available is the refraction, the wavefront guided data, the photography guided data, and we're going to plan the treatment now. The first thing we want to do a standard flap. And on this flap, we've chosen to do a wavefront optimized procedure. And I'm going to show now where the data is. So there's the profile that we're going to treat. And you see where the flap is currently, the potential is there for the hinge to address this flap. So we're going to move the flap around a little bit by making this a nasal hinge. To make the flap a nasal hinge, it fits in a whole lot better. The right eye, we're going to customize the flap by putting up the optimized profile, seeing where the profile fits in under the flap. We'd like to reposition this flap to a nasal hinge to create some space. And what we're also going to do is we're going to change the dimensions of the flap slightly. We'd like the horizontal dimensions to be slightly smaller and the vertical dimensions slightly bigger. And now you can see that the flap, in fact, has a rugby ball shape and now accommodates this ablation profile perfectly.
Looking at doing a superior hinge, I want to show specifically over here how we are speaking to the patient. I'll show you on the right eye, that's easy to see.
All right, okay, slightly to the left.
suction on, please. So target the pupil. Really good. Doing very well. Hold it just like that. And keep on speaking to the patient. That's fantastic. Beautiful. That went absolutely perfectly. See that sound now? You can be aware of some manipulation on the surface. Enter the flap vertically. And when you bring it back, make a nice taco to protect the hinge when doing the surgery. And now the nasal hinge to show you the right eye again. Base to find the middle of that white circle. Very, very good. Hold it just like that. Trying to get to the back of that circle. Excellent. All right, suction on. Very good. Hold it just like that. It's fantastic. Hold it just like that, very. So again, only applying the suction once the conjunctiva is on stretch. The second thing I'm going to speak about are 5 tips for streamlight. So generally, measure the epithelial thickness if possible, and then adjust the refractive input as required based on the epithelial refractive power. So mostly if the epithelium is uniform, whether it's 55 or 60 or even 50, it makes no difference. You simply enter the thickness and do the procedure, and there should be no refractive output. So that's true for primary eyes. If you have no epithelial maps, you can use 55 microns. If you're doing a few microns too few or a few microns too many, it's not going to make a difference to the refractive outcome. For secondary eyes, however, if no epithelial maps are available, you must warn the patient that they will require 2 procedures and that the first procedure may make the uncorrected distance visual acuity and the refraction worse, depending on the refractive shape of the epithelium. Use ice cold BSS pre and post operatively. It simply makes for better post operative pain management. And then prior to starting the ablation, make sure that the cornea is dry and has been smoothed out with a moist Wexel sponge. The excimer laser at wavelength 193 nanometers does not pass through water. So if there is a spot of water on the cornea, a small little drop, it won't pass through that, and that will be an aberration in the correction. Now, finally, 5 tips for the topalizer. Again, when you're taking these maps, ensure that the eyes are not dry. If you need to, put in a lubricant drop a few minutes before. Next thing is you need access to the eye. Tilt the head slightly to reduce the shadow of the nose on the cornea, turning the patient's head to the side. Keep the eyes open as wide as possible. You can even ask the patient to raise their eyebrows as if they're surprised. That would tend to give you more exposure. You can push up the eyelashes if they are pointing downwards and impacting the scan with your fingers or a cotton bud. And you can pull down the face mask to the tip of the nose. This is obviously in the times of COVID. And then one final comment here is you can include the eye not being scanned at the time, so that the eye that's being scanned is the focus of the attention and the patient's using that to fixate. Additionally, for any treatment that you're doing or any scan that you're taking to drive a TCAT or a Contura procedure, it's extremely important that the data is well registered and very high quality, as this is going to drive the treatment. So it's important that once the eye is aligned for a good quality capture, for the first capture, you move slightly off center after that exam to ensure that the second capture does not capture the image too quickly before the pupil can adjust to the light of the topographer. You allow the pupil to react, then take the second capture by realigning. Otherwise, you get false variations in pupil size that may affect the treatment planning. So I hope that these 5 points for each of the sections gives you enough information and enough subject matter for discussion. And all my best to this esteemed panel. And thank you again, Oftalmo University, for your kind invitation. Kind regards. And goodbye.
You have also a lot of experience. What do you think about these tips? We tried to choose the 5 big tips in every platform, right? Femto, topolizer, and streamline the technique of trans-PRK. What about your thoughts, Professor?
Well, firstly, I like what Arthur said. I agree with much of it. And I think it's good to explain what a Bell's phenomenon is to patients, because the whole time you're doing refractive surgery, you're fighting it. And if they understand what it is, they might be able to help you. The conjunctiva can get wrinkled up, and I don't use a speculum as Arthur does it, but sometimes if that's a problem, a speculum can help to stretch it out. Putting the canal in the right place is important because it's vital to getting a smooth bed. I go to the center of the cornea, and I also use much less energy than he does. 2 years ago, I had a DLK epidemic and had some really bad cases. And I think it was about air quality, but we tried everything. And I moved my energy right down to 4 and 6x6 as he uses. I think 6x6 lessens the risk of rainbow glare. With Streamlight, it's nice to have an instrument that can measure the epithelial thickness. It's not required, because we know that 55 microns, standard deviation 5 or 6, you'll be right most of the time. But every now and then you get a virgin cornea with quite thick epithelium. You might end up, if it's not a big correction, with a smaller zone. So it's nice to measure it, but not required. But in retreats, I think they're best left alone unless you can measure the epithelial thickness, because it could be 70, it could be 90, I've even seen. And you mightn't even reach the stroma by the time you've spent all the shots that you. So I think it's nice to do that. I don't use the ice cold water on it. I prefer not to do that. I just use mitomycin on all of them. But I thought what Arthur has said is very, very helpful.
Thank you so much, Dr. Wolfe. Professor Zhang, what about your thoughts? You have also a lot of experience, and I think that these tips are so important also for the young surgeons, right? That they are starting with the refractive surgery. What do you think?
Yes, I agree with the Professor Cummings and Wolfe, the points about the FS200. I think the special speculum is very important to choose for the to avoid the pseudo suction, because the very loose conjunctiva maybe is difficult for young doctors. So that's the point. Another is the centration. The centration is very important to reduce the suction time and ablation time. I have used the Intralis, Zima, and the Visumax. FS200 is the faster, only 6 seconds to make the corneal flap. And I like the FS200s. Another point is the customized flap. For the very large actimastem, I make the over flap 8.8 millimeter times 8.2 according to the estimate axis. So to reduce the more tissue cut and save the newly nerve recover time. So that's important. Another thing is for the ES500s, I think it also centration is very important. So if we capture the imaging before we lift the cap, it's easy to capture the imaging. After lift the flap, maybe to make the bed dry and irregular, maybe better results. So another thing is light. Before you capture the imaging, the pupil size quite similar before surgery and on the bed live imaging. So we should reduce the light in the operating room and also release the pressure from the patients. Breathe regularly and to talking with them, and a little bit nervous, make the smaller pupil and very difficult to capture the imaging. So a lot of time to fly and maybe cornea dry and some flap string winking and the better result. So that's the main point. And the top angle compensation is according to the WFO or custom Q or control vision. So the best choice for patients to capture the exactly at least 6 images to compared and make the average accurate images to the computer, and to make the very exact results is very important. After surgery, I think we should check the corneal flap. There are sometimes when the patients at the slit lamp, maybe some canal bleeding. So we should move the bleeding before the patients go out. Otherwise, patients and the relative worry about something. The day one, we open the flap and remove the bleed, maybe unhappy for the patients. For Streamlight, I like very much because the very thin cornea and very young patients, very low myopia, Streamlight is very important and very good procedure for them. But the issue is their nomogram. For very low refractions, maybe the corneal epithelium thickness is very important to calculation and guarded to make the exactly normal, get the very exact results, very important. And also the haze after surgery should be prevented by the steroid eye drop and monitoring intraocular pressure, and also prevent from the UV irradiations. That's for the surface aberrations. Another thing about the topalizer, I think reproducible and repeatable exactly imaging also very important, especially for dry eye or some unstable tear film, also irregular inflect the results after CV, not very happy. Thank you.
No, thank you. Thank you so much, Professor Zhang. There is a question from the public. This is an open question for all of you guys. Is there any experience for preventing AC bubble? Thomas, Ben, Rick, what do you think? AC bubble, we know this is a problem when you use the femto. So what do you think about preventing these bubbles?
When I used to have an intralaser years ago, I got them a lot. And I think that's because they got a pocket rather than a canal. And I think the canal on the FS200, I've seen one bubble and I've done thousands. So I don't, maybe I do something that stops it and I don't know what it is, but it doesn't seem to be the problem like it is with the intralaser.
Actually, AC bubble is very popular in intralaser, not the F200 and Visual Max or Zima. I think canal is the more smaller. In my clinic, I use the 1 millimeter canal to prevent from the AC bubble. Thank you.
Excellent. Before we start with the 360 experience, I would like to talk with Thomas and Ben because, guys, we were having a discussion about refractive surgery. Thomas, you said before we started something incredible, that your experience during the resident was almost zero, right? You made more pediatric cataract than refractive surgery, and that was incredible. So can you tell us a little bit more? Because now we're going to show a new kind of learned refractive surgery, right?
Yeah, I think it's a really important point, is that refractive surgery, especially laser refractive surgery, isn't taught well often in the training programs around the world, but particularly in Australia and I think New Zealand, and Ben can comment on that as well. And that lack of confidence that comes from not having experience in teaching in it, I think really turns a lot of ophthalmologists off it. And perhaps that explains why the penetration of laser refractive surgery in Australia is half of what it is in the US and a quarter of what it is in Canada. And I think that's something that really needs to be addressed going forward at the level of the training colleges, what we call our training bodies in Australia.
Oh, thank you. Thank you so much, Thomas. Ben, what do you think? How was your experience during the residence when you become a surgeon?
Yeah, I mean, I agree with Thomas. So I did my training in New Zealand and then came across to Australia to do my fellowship. And definitely during my training, I knew that I wanted to be a refractive surgeon, but it was a lot of stigma. You're not allowed to say you want to be a refractive surgeon. You have to pretend to want to be a cornea refractive surgeon or a cataract and refractive surgeon. But so it's difficult because there aren't many opportunities and you can't get that experience. There's no public experience in New Zealand with lasers whatsoever. And there's no opportunity to visit private to find out. And so I agree with Thomas that there is a stigma against it, and a lot of your colleagues don't look well upon refractive surgery. And so really the only opportunities you have are to go down that path completely and find a fellowship that offers refractive surgery. And they're few and far between. Until Arthur and the Refractive Surgery Alliance really got started, there weren't really many opportunities. So I think, I've got trainees at the moment that are sitting their final exams and they're very weak in the refractive surgery component. They're very good, like you say, pediatric cataracts, they're killing it, they're great. But laser is very weak. And I'm not sure of the way to change that. I think probably it has to start with taking it more seriously from a college point of view and making sure that it is a component. And I know that for the Royal Australasian College, they've got sort of guidelines for how many cases of whatever needs to be seen. And for the first time this year, there's a guideline on sitting in with a laser refractive surgeon. So at least that's a start.
It's incredible because also here in Latin America, sometimes in some residence programs, we don't have the possibility to have refractive surgery training, right? And so you become an ophthalmologist and you don't know anything about this. It's like you don't know anything about glaucoma or cataract, right? And I think that we need to improve that situation. Brian, are you here with us in Filipinas? Can we have your thoughts from your country, your scenarios? I don't know if Brian is connected. Well, maybe Brian, here. Are you here?
Oh, hi. Can you hear me?
Yes, perfect.
Yeah. Yes. Okay. Back when I was in training 10 years ago, the training, actually the training curriculum is totally different. We're not really, we're not really exposed to laser refractive surgery. We could only just observe it through some of our consultants. But nowadays, as I was practicing for the past 9 years, I see that there's a niche for that skill that we have to develop. Actually, I think it needs to be developed when you're in training. You get exposed to laser refractive surgery as early as your training and maybe do a few cases. Simply because if you're going to try to look at the market right now, it's probably your patients is going to somehow grow with you, So by the time the patients are getting older, they have that income, that's the time that they're more receptive to technology, unlike the time that when I was in training, the patient demographic is totally different. Okay, so I think it would be better if we're more exposed to laser refractive surgeries during our training. Yeah, so those are just my thoughts.
Thank you so much.
Thank you,
Brian.
thank you, thank you, thank you.
Our pleasure. So in Mexico City, in the Oftalmo University campus, we have an incredible OR prepared for you guys. So I want to say hello, Ivo. It's very early in the morning in Mexico City. Thanks so much for being there. Show us a little bit more about our facilities in Mexico City.
Hi guys, hope you're doing good. So many things. Here's very early, very cold. We just had an earthquake a couple of days ago. This is, very interesting situation. But I want you to be prepared for what's going to happen now. And what's going to happen now, the first thing is a 360 camera as we speak. So there's a link in Zoom, and you can also have a 360 experience while we're doing this. You're going to see all the cameras and all the stage. It's going to be cool. But also you're going to be here with me with the technique in where I'm going to ask these amazing speakers to be with us. The second thing is to thank so much to Robbie and May for making this happen. This is a huge effort from us, from everybody, to make this happen with a 360 camera, with a mobile camera, and also to have Dr. Wolfe. I had to meet him in Melbourne a couple of years ago, to have amazing friends as Ben and Thomas, who also, we met in Australia, and Dr. Zhang, thank you so much for being here with us. And we're gonna start. The first thing I'm gonna show you guys is look at this, guys. You were talking about penetration. I have my assistant right here with me using glasses. What do you think about that? He doesn't want to do surgery. He's with me the entire day here with a refractive suite. So that's an important thing to talk about. Right? Ben and Thomas were talking about training. I will talk also about not only train the technical issue, but also the communication with the patient to transmit the value proposition of refractive surgery, about the safety, about the outcomes, the predictability, right? I think that's very important. But today we're talking about the technique. So I have everything ready. As you can see, I have the refractive suite. I have you guys right here with me too. You're gonna, you can talk to my ear and also, give me some advice, because for those who don't know, I'm a cataract surgeon. I'm doing my first steps in refractive surgery. So I'm in my learning curve, okay? So in those two screens, you're gonna see all the planning. Today, I'm not gonna, focus on the planning, because you also have 360 videos that are gonna be for you in the website. And then, of course, the guys are gonna send you the link so you can see those videos. There's a 360 experience that are gonna be only available for you guys who are attending to the webinar. And, you can then, they're gonna be open for today, but then you can see it in the future if you have the correct link. And it's amazing. You can see that in the other link with the 360 experience. So the first thing is about to having an assistant, right? I'm gonna ask the panel how important it is for you guys to have a trained assistant while doing refractive surgery. Dr. Wolfe, what do you think about that?
You need a trained assistant to operate the laser. You're asking me whether we need a trained assistant. Of course we do. You can't do it yourself.
Perfect. Well, I love that. That's very simple and very clear. What about the other guys? Everybody has an assistant. It's very well trained. Ben, Thomas, Dr. Zhang.
Yeah, having someone experienced in the laser room makes a huge difference. The patient's nervous. You don't want the surgeon to be nervous either.
Andres, you did 30 surgeries yesterday, right? Tell me
Yes,
about this.
on Tuesday. Well, for me, it's a key part of the surgery. I mean, it's crucial to have a good assistance. You will feel more confident when you have someone that you trust. So, guys, you need to prepare someone with experience with you, beside with you, and that's one of the key for the successful.
Excellent. So we have a trained assistant, but we're also going to perform refractive surgery soon in him. We just can't see him with those glasses. So right now, I want you to see myself in the environment. For those who are in the 360 experience too, you're going to be understanding what's happening backstage. But one of the important things is about the pedals. There is 2 pedals in the first step, that is the femtosecond laser experience. And there is something important about the interface. You need to understand that you will have 2 joysticks. One joystick is going to be for the patient. A second joystick is going to be for, to do the correct suction. And then, of course, the femtosecond. And, you need to understand perfectly what's happening with the interface and how you are going to put it. And then you're going to, in this specific moment, 2 things: how you're going to talk with your patient and how you're going to place your hands correctly to have the most control. For example, this joystick, will change depending on the eye you're going to do. In this case, since we're going to do a right eye, I'm going to grab the interface with my right hand temporarily, and then I'm going to use my left hand and for the joystick. Dr. Wolfe, tips about this specific moment, how you talk to your patient, how you prepare for this?
Sure, you need to talk to the patient. They're getting very anxious at this stage. They can see the ring of lights, and they can you're about to touch them, and they're very anxious. You need to talk to them at this stage.
Excellent. Dr. Zhang, any other tips about this specific moment, how you talk to your patient, how you behave in this?
I think first you should place the right position of the head, and both eyes look straight, and to release them, and deep breath for the patients, and encourage them to cooperate it. Just only use the 6 seconds, so very fast. Don't worry, don't nervous. Very important.
Very good, very good. Thomas, Ben, any other tips when we're right here in this in the femtosecond moment?
I think it's very important. Sorry, I think it's very important when you apply the suction to very quickly and clearly say to the patient, "There's nothing you need to be looking at now," because the vision's gone dark. You need to tell them that, and that's according to the plan. And if you don't do that, they get very worried.
Yeah, I was just going to say similar to Rick, that this is the point where I would be saying, if you can't see anything, I don't want you to chase anything. I'll tell you if I need you to look in a direction. Otherwise, relax and you'll be doing fine.
I think that is one of the most important part of the surgery, right? To manage the anxious of the patient, right? And I mean, we need to understand that the patient is the first time doing this, and you should be anxious and nervous. So we have to talk with our patient and explain what are the feelings and what are the next steps in the surgery. Ivo, how is going that surgery? Jason was telling me that nobody's perfect. You're a cataract surgeon. You're not a refractive surgeon, but nobody's perfect. Can you hear me, Ivo? I think we lost the audio, but I can see that he's doing the coupling. And remember, guys, we have a link. So if you go now, yes, now I can hear you.
Perfect. So I did the suction, and I wanted to show you in the screen how you have two things: the ablation cone suction and the eye suction. Okay. So right now I'm doing the applanation construction and it needs to be green in order to move forward. So I have a correct suction, it's green. Now I'm gonna center it. I'm gonna put the interface in and we're gonna proceed to the second part of the event, okay? And here, we're gonna use the second joystick to do it. Okay, so you can see me here right here. I'm gonna do, and this is, tell us, Andres, we were talking about this. This is a very important step, right? This is very difficult in some in simulation in the big eyes. It's not easy.
And also, Ivo, the centration, it's the key, right, Dr. Wolfe? We need to be very careful with that.
Yes, of course. Yes, of course. You need to come down on the center of the pupil or from the coaxially sided light reflex, the rings, either one, right in the middle of it. Because once you've touched the cornea, you can't really use any XY. Use the XY, pull the epithelium off it. You've got to go straight down onto it. And this is where obstruction on facial features or brow or cheek come into it. And if you stops or decenters, it's because of that. You have to go back and do it again.
Perfect. So then I did it. You know, it's not easy in this kind of case. And then I have, as you can see in the bar, an eye contact section 2 in green, and then we are ready to proceed.
We are watching everything and it's good, perfect. And the 360 camera, it's going great, Ivo. If you go to
see how I'm doing the flap right now. I hope you can see.
Yes, perfect.
Perfectly. And now we are ready to go. What do you think, guys? Not bad for a cataract surgeon.
Beautiful.
And also, you know, the important thing about, you know, there's many tips, I agree, but then the femtosecond does an amazing job. We don't have a microkeratome here. It's very predictable. It's very safe. And it's very, you know, easy for the surgeon. I don't like the word easy, but then, you know, I think it's, if you understand step by step what's happening, I think you can have amazing outcomes with your patients with the femtosecond. What do you think, Dr. Wolfe?
Sure. Yeah. Look, there is some skill involved, though. There's a great deal of skill involved, particularly with deep orbits and heavy brows. And some of these patients, particularly hyperopic patients with small eye, can be terribly, terribly difficult. And that takes a bit of skill in positioning of the head.
Okay, great. So now I hope you can see both cameras, because then there's another important step here that people can think it's easy, but we need to talk to the patient, and now we're gonna put, you know, the bed of the patient to the exit. Tips about this specific step, Dr. Zhang, you know, how you talk to the patient, because there's many surgeons that say, okay, 50% of the surgery is ready, you need to relax, the bed's gonna move. How we communicate with it?
Usually I tell the patients, you're great. We have finished the flap. We just give the laser ablations. It's no pain. Don't worry about, just deep breath. In the same time, we can change the light in the operating room and make the pupil similar to the imaging before the surgery we catch. And after we setting the patients, we adjust the patient's head. And I usually use the red cross line to make the left eye and left eye in the same level, and also the chin and the nose and the head in the same line, especially for the very large astigmatism. For the control vision procedure, it's very important. And then I use the speculum, open the eye and cover the eyelash in case of the inflammation, infection, something. And also I flap separate the cornea flap, and very easy. So I should use the for the young doctors, encourage them very short learning curve to master the control after 200 and ES 500. And then the technicians, we choose the different procedures, custom Q or WFO or control visions. And then I ask the patients to look at straight the green line. So don't worry about no pain and release. Relax, don't worry, don't nervous. That's very important. And then we check the pupil light and catch the exactly imaging and compensate the cup angle and the circulation. And then go on. If the cup angle larger than the 5 degree, I also repeat the procedure and make sure whether the cup angles is the real or false. And then I start the laser ablations very fast, even though for the 10 diopters. And then I use the BSS to clean the bed and recover the cornea and make the edge line shine, just like the cataract surgery, the capsular red gum. That red golden ring, that means the corneal flap dislocation very exactly. Side kites make sure 300 degree not dislocations and finish the operations, but remove the speculum very carefully. Otherwise, remove the corneal flap or dislocation, something like that. Thank you.
Ivo, we are almost ready for Jason. Tell me more about your surgery, your patient. How is going everything over there?
Right now, as you can see, guys, this is simulation. And we know, everybody knows here that the flap, it's more difficult, it's more sticky like in microkeraton, but I want you to see how easy I'm doing it. Look at that. So I'm trying to just separate the flap, and the stroma, and actually it's very, very easy. There is a couple of tricks here in while you're doing simulation that you need to remove the epithelium because the pig eye, it's very difficult sometimes. But look at that, how easy it was. This is an amazing machine to do. And now I'm managing perfectly the flap. For those who want to have all the details on how to do it, the video in 360 is already recorded. And now I'm gonna do the excimer, just the final part of the surgery. Any tips about this specific step, Dr. Wolfe?
Well, it's important, of course, to have it centered and the patient to be fixating the green flashing light. So you have to encourage them to look at the green flashing light, and you're battling the Bell's reflex that they want to. If they dodge, the eye dips upwards, you just stop the ablation and say, look at the green light. And they say, oh, but doctor, the green light's moving. And I say, well, no, that's the eye moving. And the centration is automatic. You see that the ablation's going on nice and symmetrically, and it's over.
Excellent. So, maybe Jason, we're going to talk about this, but I think it's very important, and the power of simulation to learn this technique, right? I mean, I'm basically doing every single step of the surgery with a pig eye. I have the sense of the flap, how I can manage it. I also can train myself on how to talk to the patient, simulating that there is a patient behind me. I think that's very important for collaboration, because I think patient collaboration in this procedure is extremely important. We're gonna tell this guy to look right into the red light, and then we're gonna do the excimer laser. There is something important here, just to talk to the patient about how many seconds are left. Okay, so the patient knows, okay, it's gonna be 14 seconds, relax. and even sometimes you're counting and telling the patient, you know, to relax, that it's, you know, a few seconds left. Dr. Wolfe, do you agree with that? Do you do that with your patients?
Yes, I do.
Yes.
Yeah, particularly if it's a long one. You know, the important thing too is when you're beginning is to mop up the excess fluid, because often fluid collects, I presume, comes from the lacrimal gland. I don't know where it comes from. And then if you get a Bell's reflex, the water goes on the bed, and then you dry the bed, and then they look up again, you dry the bed again, and it's can be a real mess. Oddly, they do very well, but I think it's nice to keep the bed dry and be sure that there's not a pool of fluid around the eye.
Excellent. Ben, Thomas, any other tips? I already did the excimer laser. In that moment, it's very important to talk to the patient, tell how many seconds where they're left. Also, to fixate in the red,
Green light.
red. And you know, I'm just putting the flap again, something very important here too. But my message is, and it's very simple, is you can simulate this, you can train, you know, in many Alcon experience centers around the world. Here in Mexico City, we're here for you too. I think refractive surgery is an amazing technique that provides very good value proposition for our patients, and we can learn this right here. So, Andres, we're done here, so you can, you know.
Thank you so much, Ivo. It was a great performance. You are becoming a great refractive surgeon. Ben is laughing. So thank you so much. And remember, guys, you can go to the Oftalmo University website and see again and watch again this 360 experience. We just recorded a lot of videos for you, and you will see all the experience. So now, before we finish, we have the great Jason Pennycock. My friend, how are you? He has an incredible presentation with incredible topics also. So Jason, thank you so much again, my friend.
Hey, Andres, thanks for having me. As Ivo was talking right now at the end about how it's important to simulate things before we actually do them, I was remembering that a few minutes ago, Ben said that this is the first time the patient is undergoing the surgery, which is absolutely true. And it's another reason why it shouldn't be the first time for a surgeon to be doing the surgery. And that's why it's very important for us to simulate and to use all the tools that we have to learn. So I'm gonna try to share my screen. Hopefully it'll go better than last time. Give me a second. And we did try this before we started, so it should go smoothly now.
We can see your presentation.
Give me a second, because it shows here as in my sharing has paused, which was my issue last time. Can you see the presentation move?
Not now.
Not now, Jason.
Okay. Give me a second. Sorry about that.
No worries. Meanwhile, one of the questions in the survey was, why should we acquire more and better technology in our practice? And if you see the results, it's very interesting. The audience answered that for outcomes, improved outcomes, patient outcomes, because we can get more surgeries, happy patients, improve safety, because it's the gold standard. Ben, what do you think about these questions? What is your opinion about acquiring more technology for our practice?
Yeah, I love that it's all focused on patient outcomes, because that's the real reason. You have the best, if you have the best technology, you have positive patient outcomes. The key thing with laser refractive surgery is it's word of mouth referral. And if people have a good experience, they'll come back and you have a good business. You know, that's the real benefit of LASIK over PRK, is that people love it. It's amazing. And people come back the next day and they can see without their glasses. So patient outcome is the key. I like that someone has written there trendy. There is a little bit of that as well. It's nice to be able to say, you got the latest and greatest, but really it's about outcomes.
Absolutely. Thomas, there is another good answer, precision. I love that, right? What do you think, Thomas?
Look, I absolutely agree with Ben that you have to have the best technology to have the best outcomes. But I also think that Barry Siebel said it best when he said, you have to optimize your technique before you turn to technology. And so you can't just buy better equipment and hope that you'll be a better surgeon. You need to make the most of the equipment that you have, and that makes certain that you get the appropriate training and really try to use the technology that you have to get the best possible outcomes.
So this is actually a perfect discussion to begin. I actually had two questions that because of time, I'm going to have to cut a little bit short. So I want to ask Professor Zhang, what is your favorite tool as a refractive surgeon? If you could sum it up to 2 or 3 words.
Because nowadays we use their technology for the patients want to get the high quality and long stable result and satisfaction. So the technicians should be improved in the remove the hard high order operations automatically. Nowadays we calculate much more about how to relieve the high order aberration to compensate the low order aberrations, make it exactly normal for the complicated cases. So I think in the futures, maybe should be improved automatically to compensate the low order aberrations before we remove the high order aberrations.
Perfect.
Nowadays,
so
I like the
automating your process.
Yes.
Thank you. That's excellent, Dr. Zhang. And Dr. Wolfe, considering that you're a pioneer and early adopter of cutting edge technology, how do you decide what technology to adapt or to adopt and what technology to ignore?
That's a really hard one. I've been through so many iterations of devices. I started in 1991 and then did LASIK in 96. And choosing LASIK was the best thing I did. And you could see that getting better quickly was important and the safety was high. There was nothing scarier than running an old microkeratome across the eye. Unless you've had the experience, you'll not know exactly what it feels like. But then going to the next big decision to make, although there are minor decisions, the next big decision is, are you going to go for customized? And my view was it's all about customized. We had wavefront guided, it was okay, but topographic guided, to me, is the pinnacle of achievement compared to, say, SMILE, that is just uncustomizable. The technology is not available to customize it. And we've seen John Kanellopoulos' fellow eye randomized study where Contura was better in every single visual measurement made. So why would you adopt a technology that could never beat anything else? So and then I think we're looking forward to ray tracing, which might be even better. My big disasters with the camera inlay and the raindrop inlay, I should have known better.
Excellent. Thank you for sharing. I want to highlight something that you said, and is rapid improvement. And you also mentioned a lot of database decision making. And that's what we want to talk about today. So we want to talk in the evidence toolkit about the best tools to climb higher and how you can optimize technology to your advantage. As we start, we have to live as we're climbing. And I wanted to share with you guys this quote. Some mountains only require a good pair of shoes, others require an entire toolbox to conquer, and knowing which is which is the key to success. So how can you think about that? How can you go about having or picking the right tools? And then these are the messages from the evidence toolkit. You have to keep your toolbox updated. You have to know that each toolbox or each tool has a purpose, and you have to use your tool safely. So when we talk about keeping your toolbox updated, today we have a lot of different techniques. There's certain things that are coming up down the line, like lyric, but whenever there's a new technology that offers clear advantages for the patient, career advantages that are patient-centered, that are safety-centered, and that are outcome-based, evidence-based, then we need to think about moving on to those as quickly, as safely, and as possible, as quickly as it's safely possible. We need to remember that each tool has a purpose. So I'm taking two examples here, trans-PRK and femtosecond LASIK. So if you have a patient that has thinner corneals, that they have in certain selected cases where you can suspect a keratoconus, patients with a small refractive error, patients that are a lot more anxious or that have predisposing factors, then a trans-PRK might be the best option for them because the technique is touchless, it's quickly done, and the patient spends less time in the, on the bed, on the surgical bed. On the other side, if you're talking about people that are in the millennial generation, people that are in medical tourism or have an active lifestyle, or your correction has to be bigger, or maybe they have a lower pain threshold, then these patients are better suited for femtosecond LASIK. So the idea here is you have to figure out what is the best tool for your patient every single time and then use that tool. And then when we talk about using tools safely, then number one is we need to remember that elective surgery must be safe. If you're performing elective surgery, then there's no excuse. It must be safe. And that means that patient selection must be strict. You can't, this is not a good type of procedure to bend the rules. You have to be strict about what you do. You have to use the right tool at the right time, every single time. And as a surgeon, you need to be humble and honest. Sometimes you're going to have to tell your patient, no, this is not the best procedure for you. Or yes, this is the way I would go for you. Or no, I cannot guarantee that kind of result. This is what I can do for you. So we have to be humble and honest and keep that communication line open with the patient so they know what they're getting into. And so we can tell them and have patients that are satisfied and not patients that regret or have a bad experience with their procedure. Someone said once that when you talk about complications before the surgery, then you have informed consent. When you talk about complications after the procedure, then you have lawsuits. So let's remember to have timely communication. And once again, if you need to optimize your technology, you need to update your toolbox. You need to remember what the purpose of each tool is, and you need to use those tools safely. I would love to connect. Please find me on any of your social media. And remember that let's lift as we climb. Thank you.
Thank you so much, Jason. It was an incredible and wonderful presentation. We're almost done. I really want to thank all our panelists and speakers today. We had a great summit again. Next week, we're going to have the third one, and Dr. John Kanelopoulos from Greece, Anshali Gupta from Australia, Dr. Nitin Balakrishnan, I'm sorry for my English with these names, it's not easy, from India, and Dr. Rosman Mohammad from Singapore. So Robbie, May, hope you enjoyed this summit, this webisode, because it was incredible.
Thank you very much.
Yeah, it was fantastic. You guys always do a great job. Really love the 360 OR. That was an amazing thing.
Thanks to the audience too. Yeah.
For the audience, Dr. Rick Wolfe, was your first time here with us. Hope this is just the first one, and we have many coming with you, right? Thank you so much.
Enjoyed it. Thank you very much.
Thank you. Professor Zhang, thank you so much also for being here. It was a pleasure.
Thank you so much. It's my pleasure.
Ben, Thomas, Brian, guys, you are simply amazing. Thank you so much for your amazing predisposition, for your discussion, your thoughts. It was incredible.
Thank you very much. Thanks.
Thank you, guys. Ivo, can you hear me?
Yes. What I just want to say is thank you. We have many places like this in the world. It's very important, as Thomas said, to train ourselves before we face our patients. There is so many things to come here and pre-op that we have been doing so many activities too, right? So everybody can become a refractive surgeon. We just need to train ourselves. So we're going to be waiting for everybody who wants to train with us here in Mexico City.
Absolutely. Go to the oftalmouniversity.com website and you will find the courses, the experience, the 360 experience, and hope to see you in Mexico, guys. Thanks to the audience. Lisandro, Jason, my friends, thank you so much. See you next week, guys.
You.
Thank you. See
Bye.
you.